So Gil, let's start. Very general, basic questions for TRT newbies, but maybe they want to have a lot of information in a short amount of time. So let's go.
Hi, and welcome to the TRT and Hormone Optimization YouTube channel.
What are the benefits of testosterone replacement therapy?
Well, the benefits are replacing a deficiency, right? If you have been diagnosed with a deficiency, keeping this short without going into all the signs and symptoms of the deficiency, essentially by replacing them, you're going to negate all of the ailments that come along with the deficiency and potentially prolong and improve the quality of your life. So we can go into far more detail about what each one of those means, but in a nutshell, we want to arrest and potentially reverse any adverse effects of testosterone deficiencies.
Right. So what are the risks and side effects of TRT?
Well, the risks are higher when done incorrectly. So the first step anyone should consider is finding a competent provider who truly understands hormones. Just because they advertise that they do does not mean that they do. Channels like this are a godsend for anyone who is new to this field and wants to do a little bit of research before they go on their own journey. So I do advise everyone to find the correct provider, and then all of the education and proper treatment management will follow suit, because again, we can spend an hour discussing risk versus reward, but the goal here is to stave off any risks and side effects, and obviously just benefit from the upsides of treatment.
All right. Question 3, is TRT for life?
Is it for life? It should be. It doesn't have to be, okay? No one's going to die if they come off testosterone. We need food and water. We need air. We don't need testosterone per se to remain alive, but we do need testosterone to remain alive with a good quality of life. So if you went on for the right reasons, which is to treat and reverse a deficiency, that deficiency will not self-correct on its own, especially as you age. It's only going to get presumably worse. So the goal of a deficiency, just like if you were insulin dependent, you'd be on insulin for the rest of your life, although you would die if you didn't have your insulin. With testosterone, it's not quite as drastic, but you certainly want to replace it for the rest of your life.
All right. How many times per week will I have to inject?
Again, that's going to come down to several factors, including your SHBG and other binding proteins and lifestyle, metrics. But that's for your provider who, again, if they're competent, they're going to advise at the bare minimum. If you're using testosterone cypionate, the bare minimum is twice per week in a minimally invasive protocol, which I have made a video on our clinic's website, video number 68, which is a 2-minute video teaching you just how simple it is to self-administer at home.
All right. What is the best TRT dose?
Dose, again, there's no cookie cutter approach. It's going to come down to you and your provider managing you correctly. Dosing is very specific. With any medication, there are specific doses that are designed for different individuals. With hormones, it's even more multifactorial than just height, weight, etc. There are other factors that go into it. There's cascades of upstream hormones, downstream metabolites, and whatnot. So everything should be taken into consideration. Full subjective assessment should be performed. Objective data should be considered, and then feedback from the patient on evaluation should also be considered. So dosing is something that is tailored for an individual and is adjusted on the fly throughout the course of treatment.
Mm-hmm. What if I don't want to inject? Are there any other good options?
So testosterone compounded cream, not to be confused with gel, is a viable option, which I believe you yourself have been using for many years. Personally, I'm not the biggest fan of cream, as we all know. I do prefer the injectable protocols, but anecdotally, cream has been shown, when done correctly and dialed in, for many individuals to work quite well. Outside of those two options, excuse me, I really would not consider any of the other forms. Jatenza, which is a name brand oral, absolute junk. 1.62% alcohol-based gels, absolute junk. Pellets, complete and utter junk. Any of those administration, now they even have a nasal spray, any administration form short of a compounded cream and an injectable form of testosterone, I certainly would not consider or recommend for anyone.
What's the best spot or site on the body to inject TRT?
So my video teaches how to use the lateral delt. Okay, and then the ventral glute is also a very non-invasive, minimal pain area. It's fairly avascular, not a lot of nerves that run through the area. It's a nice little pad there. And if you use a 27 gauge half-inch insulin syringe in both of those locations and you rotate left to right, you could do this for the rest of your life. Minimal scar tissue, if any, and like I said, no pain and occasional minimal bleeding, if any.
You already answered, but what's the best needle to inject TRT?
27 gauge half-inch, bar none. If you watch video number 68 on elevatewellnessgroup.com under our knowledge base section, there is a demonstration of it. It's a 2-minute video. Everybody should be able to access that for free.
Another question that keeps on returning, are SubQ injections as good as IM injections?
There have been studies suggesting that they were. What I will say is don't worry about it. Inject on a 90-degree angle with a half-inch. And if you happen to, get into a shallow muscle or a deep SubQ, the absorption rate seems to be fairly similar. I do not recommend belly SubQ or 45-degree SubQ injections. They do tend to nodule up a little bit and take time to dissipate. Absorption has not been shown to be quite as efficient as intramuscular due to, again, and relatively avascular tissue in adipose layers. So I would recommend watching video number 68 and addressing it according to the way the video shows.
After starting, when will I have my first blood check?
Every provider has their own protocols. In my office, we like to go 8 weeks out. Testosterone cypionate, which, as you know, has a 7 to 8 day half-life, takes about 35 days to reach a steady state, which is 5. Basic pharmacology teaches us that 5 half-lives is a steady state in any medication. So 35 days to hit steady, about another 3 to 4 weeks of living in that state. So we can look at the objective data at day 35. We want to give you another 3 to 4 weeks to get proper subjective data once you've hit steady state. And that's when we do our reevaluation. It is a short enough period for us to assess and make adjustments. It is long enough for us to get a clear picture of what's going on with your treatment.
What's the best moment, how many days after or before the injection to have blood drawn for control?
So the rule of thumb, right, in medicine is that you always test a trough. So you want to test just before the next administration with a relatively medium-acting ester like cypionate. If you're frequenting correctly, which is 2 to 3 times per week on average, depending on the individual, and as we know, some individuals with low SHBG microdose daily, you really should have pretty steady state throughout the entire week. So I tell my patients it's really irrelevant when managed correctly, and you can really get your labs drawn at any time because we're trying to avoid peaks and troughs, right? We want like a nice little sawtooth graph and not these peaks and valleys because hormonally we don't want to send people into a cycle of feeling great and then crashing. So we try to aim for that, level where they feel their best and to just move the bar up and down laterally.
What's the best time of day to inject TRT?
Find a time that's convenient for you, stick to it, and create a habit.
What if my hematocrit is high? Do I have to donate blood?
You do not. So Dr. Rouzier has a great piece on this. And again, it's a little lengthy, so I won't go into great detail. I will say hematocrit is merely a dilution ratio. We can improve dilution ratio by hydration. So if you hydrate better, your hematocrit will come down. Even without affecting any change to RBCs. Remember, most people go into a lab draw fasted. And for layman's people, the word fasted means NPO or nothing by mouth for 8 to 12 hours. So make sure you drink, at least 2 of these 17-ounce bottles prior to your blood draw. You don't have to eat food, but you do want to drink water so that the blood flows smoothly and that your hematocrit presents a true and accurate number rather than a dehydrated number, which is often common in the morning.
Also, a question that many beginners have asked, do I have to take anything else on TRT? Vitamin D, DHEA, pregnenolone, magnesium, and if so, who will tell me what and when?
So TRT and proper nutrition are mutually exclusive. Whether you're on TRT or not, you should replace any deficiencies. Most people who live in America, at the very least, and I would imagine Northern Europe as well, are vitamin D deficient. So a good D3, 5,000 IUs per day is a nice, average dose for sustainability, which is, by the way, about 2.5 times the recommended USRDA, which is completely outdated from the 1950s. You couple that with a K2, which helps absorption, unless you're contraindicated with a blood thinner. Other than that, there, zinc, magnesium, vitamin C, we can go down the list of essential vitamins and minerals and spend 45 minutes discussing that. But at the end of the day, whether you're on testosterone replacement or not, you should address whatever vitamin, mineral, and nutrient deficiencies you may have as a result of malnourishment.
What if my estrogen is high?
There's no such thing as high estrogen in men if your testosterone is optimal. Okay, so if you have optimal testosterone level, estrogen in men and in postmenopausal women as well is not an endocrine hormone. It is a paracrine and intracrine acting hormone. It is aromatized or converted or reduced within the cells of its target tissues, and serum levels are merely excreted hormone. 85% of estrogen in men is excreted via urine. That means it circulates through the blood into the kidneys and eventually is urinated. So we don't even test estrogen serum levels in our men. We have thousands of patients doing very well for many years. None of them on our aromatase inhibitor or have their estrogen levels checked at all once testosterone is optimal.
Clear. Is TRT bad for the heart?
No, TRT is actually very cardioprotective, and one of the cardioprotective properties is the metabolites such as estradiol, B17, 17 beta estradiol specifically, is extremely cardioprotective. It's been shown to help to regulate endothelial function in veins and arteries. It is protective of muscle tissue, smooth muscle tissue, cardiac tissue, and the risk of MACE or major adverse cardiac events has been shown to be reduced when men have optimal testosterone levels. In fact, a study I've looked at recently, which I've seen years ago and then recently popped up again, was how low testosterone greatly increased the risk of cardiac events. So optimizing correctly without the use of aromatase inhibitors, without the use of incorrect frequencies, and utilizing a good provider who truly understands hormones actually will greatly increase cardiac health.
Mm-hmm. Sure. Will TRT increase the risk of prostate cancer?
So Abraham Morgentaler, as you know, is a prominent urologist out of Harvard Medical, and he's published many papers, I think over 20 papers in the last 5 years from Morgentaler, specifically relating to prostate cancer and testosterone replacement therapy. Now, as you know, urologists have always used something called ADT, which is androgen deprivation therapy. It is essentially chemical castration for men on active surveillance or with prostate cancer. They believe that DHT, which is dihydrotestosterone, the second prominent metabolite of testosterone after estradiol, which is converted via the 5-alpha reductase enzyme, that it was responsible for the enlargement of prostate, benign, BPH, and whatnot. So, in fact, he's proven via various literature and studies that DHT and testosterone do not increase the risk of prostate cancer, do not proliferate or exacerbate existing prostate cancer, and he actually continues TRT treatment for his patients while on active surveillance. So the short answer is no. And the literature is out there supporting it.
Mm-hmm. Will TRT make me go bald faster?
Well, that's a funny question coming from you, right? The short answer is no.
I was bald before TRT.
Exactly. So look, I've been on TRT for a decade, right? I haven't lost a strand. I will say that if you have the male pattern baldness gene, which is a genetic predisposition, it comes from your maternal grandfather. So your mom's dad, presumably, is where they found the gene lineage. If you have the male pattern baldness gene, you're going to lose your hair, and it is inevitable, and there's nothing you can do about it. No amount of 5-alpha reductase inhibitors like dutasteride, finasteride, etc., can prevent it. DHT will potentially accelerate the rate at which this occurs. So if you were going to lose your hair at 50, you may lose it at 45 when your testosterone is optimal. With that said, it's a phenomenal trade-off, if you ask me. Again, it doesn't cause it. It does not necessarily make it happen if it wasn't predisposed to happen genetically, but it will potentially, not guaranteed, make it happen a little bit sooner. If you're going to utilize a medication to help stave that off or delay, like finasteride, you are at risk of suffering what's called PFS or post-finasteride syndrome. Again, a whole nother topic we can spend a lot of time on, but I suggest you Google post-finasteride syndrome and avoid any such medications.
I was searching for a picture of my grandfather. I found it already. Yeah, so this is my grandfather, the father of my mother. My mom died. He died a long time ago, but he was bald without TRT, of course.
You guys are twins. You're just more muscular.
Yeah, well, he was pretty muscular himself when he was young, but there he was 60, 65, so
Well,
All right. Last questions there. Will TRT solve my sex drive and erection problems?
will it solve it? Well, again, multifactorial. If the state of low T is what led to those problems, and this is a big and, if those problems have not been ignored for many years, where they potentially went from a hormonal issue or an endocrine related chemical issue to a physiological occlusion, which does occur with neglect, then potentially the answer is yes. If there are other underlying factors and comorbidities that potentially may lead to these conditions, then simply replacing the underlying factor of low T, while healthy and certainly may resolve other things, you may not reverse all of the manifestations that started with low T. Again, the longer you wait to replace it, the less likely things are to go away without further intervention. So the short answer is maybe. And again, this is why you need a proper evaluation by someone who truly understands what these dysfunctions mean, how to fix them, and how they correlate to proper hormone treatment.
Mhm. Last question. Will TRT help me lose fat and build muscle?
The only thing that's going to help you lose fat is the laws of thermodynamics. Okay, you need to be in a negative energy balance. You need to train properly. You, as the author of a book specifically on nutrition and training, obviously know this as well as anyone. Whether you're on hormone therapy or not, it still comes down to negative energy balance in order to generate lipolysis. Testosterone will improve base metabolic rate. It will improve protein synthesis and the rate at which your muscles can process the nutrients that they are given and recover. With that said, you'll be able to train more intensely. You'll be able to likely eat more food and still have more of it processed towards muscle. So will it help in a general sense? Yes. Will it help if you're laying on the couch and watching TV? No, that is a flawed approach. You need to still put in the work. You need to put in the effort. You need to be properly educated on proper nutrition. You need to define your goals, and you need to draw a plan backwards in order to meet them. If you don't have a blueprint, don't expect to build a big house.